Good morning. Thank you very much. I'm now unable to come in. Apologies that I could not be here for an earlier segment of the program. Distinguished Dr. Shiv Sarinji, Dr. Azia Pense, Dr. Kapil, distinguished participants, academics, researchers, program lead from other countries. I am truly grateful to you for giving me this opportunity to be amongst you this morning for celebrating the start, celebrating the launch, the early phase of its launch and implementation of a very important initiative in the space of non-communicable diseases. We had an opportunity to look at the burden of liver disease in our nation, and we realized that it is a neglected priority in terms of public health priorities. It is intimately connected to other non-communicable diseases, as you have heard in the presentations that have preceded today. It turns out that there is a way to address this problem. Primary prevention is possible, secondary prevention is possible. And putting a public health approach, initiative taken by Dr. Serene and his team, and alongside partners such as the WHO and partners such as other academics and institutions of the country, a blueprint, a strategic paper, an approach has been articulated over the last 2 years. We are happy that it is now part of our national program on NCDC. Sorry. And we are happy that early implementation is exciting, and it is also getting attraction and traction globally and in the region. I welcome on behalf of the Government of India, doubly welcome indeed, all the participants from our other nations. Very, very pleased to be connecting with you, and our best wishes in the shared agenda. I have had an opportunity to be in touch with the team about the developments in this area on the ground. I'm also aware of the fact that several scientific underpinnings are getting refined. We're very happy that the global community through the Lancet publication is now also more in tune than ever to this very important area of work. And such publications have also doubled our faith in the approach that this nation has taken as, shall we say, baby steps to begin with. I would only like to make 2 or 3 key points in today's meeting. My first point is truly that I urge you that we should have an important component of learning from the early implementation. I don't want to use the word pilot implementation, but essentially what we are learning by implementing the primary care approach for NAFLD, be watched, be implemented systematically in an implementation research mode, and measured the impact and other lessons thereof. This is very critical because in classical approach to public health, we develop an intervention or an intervention package that can be a vaccine, that can be a behavior change approach, that can be a social mobilization, that can be a screening procedure. Typically, as academics, we would like to see that developed on the ground, tested on the ground, typically through cluster randomized trials, especially in the last 20, 25 years, and then place those approaches for implementation.
And it's actually,
in the large spectrum of NCD, this pathway, which emerged in communicable diseases and maternal and child health diseases, child in particular, that I'm familiar with, has been altered because if you compare the approach, how diarrheal disease program or pneumonia program was implemented, was taken to scale, and recommendations made for, let's say, zinc or ORS. Massive studies were carried out. Impact was shown in terms of disease burden prevention, as the case may be, or treatment, and lives saved. Pneumonia program, for example, in children, or vaccines. We were testing this before it could be made a part of a WHO recommendation or a national recommendation, or being a part of the national program. But this has really not happened in the space of NCD. And I'm bringing this up because the WHO is also listening, and they're partners today. This has not happened in the space of NCD. It has happened to some extent in cardiovascular disease, some extent. We have, based studies in the community, which are observational studies, cohort studies, and so on and so forth. Some efforts, maybe significant efforts in community-based intervention on salt reduction, this, that. But truly speaking, for non-communicable disease, this approach has not been in that linear sense. And of course, when you extend it to diabetes, it becomes even more soft. And when we extend to NAFLD, I think we have a gap out here. The point that I'm trying to convey to you is we have put out an approach which we think is workable, which we think has strong scientific underpinnings, which we think has the best thoughts put together globally and nationally, but we have not tested it on the ground. If we couldn't do it before bringing it to the program, and that did not have to wait, I was party to bringing it to the program, then it is our duty that we create all the tools for its implementation based on the intent reflected in the base document, in the document that you all have developed as experts. So bring all the tools that are required: training tools, screening tools, how is a particular test to be done, education, community, and then tools for behavior change, because a lot of NAFLD prevention strategy, the primary prevention, is about weight reduction, for example, as I learned, and so on. What are those tools? So do we have now the full quota of tools that we require? That's the first thing. The second is, then we apply, let it move in the national program the way it is moving in the standard way, as a part and parcel of a larger program, centered particularly at the health and wellness centers. But then please have large implementation, early implementation programs, which are driven through the eye of effective intervention, and then measurement of the processes, and then above all, measurement of some outcomes of interest. Ultimately, the outcome of interest should be mortality, morbidity, etc. Apart from that, there could be other indicators such as behavior change, etc., etc. That's for you to decide. So in a short, the point I'm making is that we need, for us to move further with confidence, it cannot be only expert opinion. Expert opinion was there for hydroxychloroquine. When it was tested systematically in COVID-19, it has been thrown out. So we don't know whether this approach will actually make a difference. We think it would. And we may have to refine it in certain ways. We may have to do an ultrasound in the community. Right now, we are saying for ultrasound and detection, we will do it at this level, which is fine. But does that system work? How does it come closer to the people? How often the test should be done? The approach that we take for primary prevention, does it change at all? Alcohol, can you change behavior of people at the population level? That's the part of the package that I see. Can we change food habits? Of course, it is related across NCD. I agree with you. But where is the approach that demonstrates that on a population level, such a change can happen? And then there is the layer of secondary prevention, that the progression of disease can be stopped. These are the public health imperatives. And these need to be implemented in the best possible manner, for which you need tools, and we need a measurement matrix to say that it's being implemented. In a research setting, we ensure that everybody who's supposed to take the drug takes the drug or the placebo. If there's no coverage, If only 30% compliance happens, we cannot expect the result. So at least in our quote unquote community research or health systems research or community-based research, we demonstrate compliance, coverage of the interventions that we are aiming at, which include, as I said, testing and behavior change, etc., and then measuring the change that we think will happen as a result of this approach. So first, my very strong request, and this, Razia, you may like to do this study, across nations, same protocol. You have done it. You have done it in the space of child health, in the space of MDGs, kangaroo mother care, and others, and there may be other such interventions. So I request that that piece be thought out right now. This particular mission has been driven by academics, and we value that immensely. But I think now that we have the concurrence of the government to take it forward, we must mount a very high quality implementation research, very, very high quality. It should not be on a minuscule scale because you will not get the numbers that you want. It should be multiple districts, and the change should be visible. Money needs to be spent, protocols need to be spent. Some people have to devote 100% of their time to do so. So this is my key recommendation that I would like to bring to you. And this time for this is now, because longer you delay, less will be the confidence as this program picks up, because this program happens to be, a composite of several other pieces, because that's how it is. We are not in the space of now, the GOBI days for child survival, growth monitoring, oral rehydration, breastfeeding, immunization. There is so much more for child. There is so much more for adult. There's so many components of the NCD, from cervical cancer to diabetes to and other diseases and so on, and kidney disease will come tomorrow. So we should be ahead of the curve in terms of the implementation science and also other learnings that will come. Even biology marker learnings could come as a layer of this particular approach. So that's my key input to you. My second input to you is very carefully, kindly think about, when I read your documents, I get a sense that NAFLD is an entry for liver disease. Kindly think whether at some level, very important considerations need to be given for what you do at the secondary after detection part, which means a pathway that leads you toward hospitals and other opportunities get opened up. How do you handle that part? Because unless we look at a very strong secondary prevention component, I'm not sure whether that component is right now strong in this one. But I think indirectly I'm conveying to you that one is the base activity, screening, etc. But then at times that can happen, but for example, hypertension screening is taking place. But do we close the loop? Do we ensure that 90% people who have detected hypertension now on treatment, on optimum treatment, and 90% of them have controlled blood pressure? These are the public health goals. So similarly, on that secondary prevention aspect, how you tackle, I'm not sure whether we have wired it fully, we have budgeted it fully or not. Again, I think implementation research and experience would help us to do that. But I today would essentially like to compliment you that a part of the continuum of the non-communicable disease. That is a very strong point in the approach that you have developed as a part of continuum of non-communicable disease spectrum. We have put in a very, very critical area, critical priority, critical health loss due to the liver disease, and we have taken, in a way, lead as the group of academics that I see on the screen today. So I compliment you, I congratulate you. Moving forward, the science must continue to build and develop. The practical lessons must continue to get evolved. But then please do not lose sight of what change you wanted by having this program. Define what is the change that we want at the population level. Do we want that at the end of this program, implemented fully for a certain period of time, there will be a reduction in individuals with NAFLD? What is that prevalence that you will change? Do not lose sight of that, because that is what we have committed ourselves to achieve. My congratulations to Dr. Sareen and the team. My congratulations and thanks to WHO for being a partner for this path-breaking initiative coming from India, and I'm very, very grateful to colleagues from Southeast Asia region countries for lending your ear and lending your intent, and we will work on this together. We will, after all, in our region, we have so many commonalities from genetics to epidemiology, and we would like to work together on this, taking this mission forward. Thank you very much, Dr. Sareen and team. Thank you.